Thank you. All right, good evening. The October 26, 2020 board meeting will now come to order. Mrs. Moak, please read the roll.
Mrs. Buttimer.
Here.
Mr. Estes.
Here.
Mrs. Hill.
Here.
Mr. Lobach.
Here.
Dr. Bruno.
Here. Mr. Guzman and Mr. Curry notified the superintendent that they would not be able to be in attendance at tonight's meeting. May I have a motion to allow Mr. Guzman and Mr. Curry to participate by phone for tonight's meeting?
Motion. Second.
Any discussion? Roll call, please.
Mrs. Buttimer.
Here.
No, that's a yes.
Yes. Yes.
This is, thank you. Mr. Estes.
Yes.
Mrs. Hill.
Yes.
Mr. Lobach.
Yes.
Dr. Bruno.
Yes. All right. Mrs. Moak, roll call.
Mrs. Buttimer.
Always first, huh? Here.
Mr. Estes.
Here.
Mr. Guzman.
Here.
Mrs. Hill.
Here.
Mr. Lobach.
Here.
Mr. Curry. Dr. Bruno.
Here. Thank you. Mr. Lobach, will you lead us in the Pledge of Allegiance, please?
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
The public hearing will now come to order. The fiscal 20 budget includes certain construction projects completed during the summer of 2020, which totaled $2,990,000. The expenditures for those projects must be recorded in the Capital Projects Fund. During the planning for these projects, financial resources were identified to be transferred from the Education Fund to the Operations and Maintenance Fund, and then to the Capital Projects Fund. This resolution permits the treasurer to transfer the funds that are part of the fiscal 21 budget. Members of the public who wish to address the board on the fund transfers should check in with Mrs. Moak, the board recording secretary. She will call your name when it is your turn to speak. Speakers are asked to maintain respectful decorum and limit comments to 3 minutes or less. Is there anyone who would like to make public comments? Seeing none, may I have a motion to close the public hearing?
Motion.
Second.
All in favor, say aye.
Aye.
Aye. The public hearing is now closed. It is now 7:03 p.m. and the regular meeting is now in session. And we will open up with reports from our superintendent, Dr. Kieskowski.
All righty. I'm going to, again, keep my report a little bit brief tonight. We have some members of the Yale Saliva Direct team with us, but before I introduce them, I want to share a couple key points from my meeting today with the DuPage County Health Department. I want to share a statement from their website. So I'm going to bear with me, read this, but it's kind of new information from them. So as COVID-19 cases continue to rise locally, the Return to School Framework recommends that school officials review and consider the level of disease activity in their communities as they make decisions about if and when to shift between learning models this school year. DuPage County Health Department has been working closely with the DuPage ROE and school district administrators in DuPage County to help inform plans for safely reopening schools this fall. Their newly added note says, DuPage County Health Department supports the decision-making authority and discretion of superintendents in DuPage County to determine the appropriate learning plans, whether remote or in person, and implementation for their school district. DuPage County Health Department has worked collaboratively with superintendents to equip them with the public health guidance and data necessary to aid and inform their decision-making process during any transition level. DCHD is not able to and does not have the authority to endorse the safety of any specific decision made by superintendents within or outside of the recommendations provided in our framework. As stated in our framework, we encourage DuPage superintendents to consider individual school-level factors such as case and outbreak activity, specific disease trends and distribution, absenteeism among students and staff within a school, ability of the school to implement key mitigation strategies, and alternate remote learning site options and safety protocols when making the decision for their school community. I just want to mention this because I know we've been asked questions about where our decision-making comes in and how the county weighs in and provides guidance to us. So I just wanted to share that those are all of the things in addition to the metrics and other factors that we've been talking about that get weighed into the decision-making. And for a while, I anticipate that we're going to be looking at this on a week-by-week basis. I hope this information helps everyone to understand that there are no absolutes as we learn more about navigating COVID-19 in terms of school decisions. We have the ability to implement an adaptive pause at a specific grade level, specific school, or for the district in a whole in the event that we see school transmissions increase. At this point, none of our positive cases have been contact traced back to say, to give us reason to believe that the transmission took place in school. There were also some key messages that the county health department asked all of the DuPage County school districts to share. So one of the frequent questions that they're getting is what is causing the increase in community transmission rates? As per Karen, and this is not a direct quote, the bad news is that too many people are not following the mitigation strategies of wearing a mask, physical distancing, and hand hygiene. The good news is that this is totally in the community's ability to change. We know that 40% of the spread comes from those who are asymptomatic. Please adhere to the precautions. COVID-19 is now the third leading cause of death in the United States, following behind cancer and heart disease. There are simple strategies that make a big difference for number 3. Let that sink in for a minute. I'm sure many people wish they could say the same for heart disease and cancer. Prevention is crucial. The increase in cases is not explained by the increase in testing. Our case numbers and positivity rates are also increasing. Another thing that we discussed today is that IDPH will soon be posting data about positive cases for school-age children and school staff. However, the data will not indicate where the transmission took place. This is likely to cause a high level of confusion and will give the perception that school transmissions are higher than they actually are. This is something that I'm going to ask everyone to stay tuned for more information. So as our community knows, we've been investigating and learning about the importance of surveillance testing and how testing may play a role in school mitigation efforts. Tonight we have Dr. Ann Wiley and Cheney Kalinich from the Yale Saliva Direct Research Team. Dr. Wiley is an associate research scientist in epidemiology. She, along with Dr. Nathan Grubel, led the development of Saliva Direct. Cheney Kalinich is a member of the Department of Epidemiology of Microbial Diseases. Not easy to say with a mask on. Cheney recently earned her master's in public health with a concentration in public health modeling. Cheney is also, and maybe most importantly, a District 41 alum. We are absolutely thrilled to have both of these experts join us tonight to help us continue on our path of learning about surveillance testing and how it may impact school districts as we navigate this pandemic. Dr. Wiley, I'd like to turn it over to you to get started.
Thank you. Thank you for having me. So Cheney and I had actually discussed going in the reverse order, but I'm very happy to begin and sort of introduce the work, how we got here, and sort of what's led on to just basically what we've experienced and found in the last few months. So I'm just going to share my screen. Oops, I appear to maybe have captions on. I'm sorry. As long as that's not too distracting, I will leave them on for anyone who may be interested. So our research really started back in March when, we did find that we knew that the outbreak was approaching New Haven. And so a really large team of researchers across the Yale School of Public Health, the Yale School of Medicine, Yale New Haven Hospital, really across the university, just really banded together to form the Impact Biorepository. The goal of this was to collect samples from individuals who are diagnosed with COVID-19 that could help us to really understand COVID-19 disease progression and SARS-CoV-2. And it was through this work that we were able to compare different sample types, and has led us to our work validating and optimizing saliva as a sample type for SARS-CoV-2 detection. So we experienced so many problems, like so many people did very early on in all of this. And a lot of these really centered around the nasopharyngeal swab. I mean, I think everyone has heard how difficult it is for healthcare workers. It is considered an invasive swabbing technique. It is uncomfortable. There is risk to the healthcare workers who are taking those swabs if it means that the patient then sneezes or coughs on the healthcare worker. We also saw a lot of supply chain issues with these swabs. And, very early on, we recognized that this was not going to be an ideal swab going forward. And I think we've all come a long way since then. And we do see other sample types, including such as the nasal swab now. Originally, we were processing all of our samples that were coming through. So we were receiving from these COVID-19 inpatients, as well as asymptomatic healthcare workers, at least nasopharyngeal and saliva samples, but we're also receiving other upper respiratory tract samples, urine samples, blood samples. And we were processing these all the same way by RNA extraction, and then using qPCR or RT-qPCR detection for SARS-CoV-2 RNA. Both of these processes, however, were both expensive, labor intensive, and again, they fell under supply chain pressures. They were also just drawn out. I mean, the PCR detection required us to do 3 reactions per sample. With this, I should really stress is that we were using, and we still continue to use, the N1 primer and probe that is recommended by the CDC. And we also have a human control gene in there that we target just to sort of maintain sample quality. But, we found just all throughout these a number of issues with these swabs, with the RNA extraction, that sort of made us question, were there going to be better options going forward? So as we saw these nasopharyngeal swabs coming in, we were also looking at the results from saliva testing. Saliva is not a traditional diagnostic fluid. It wasn't being collected in very many places. Again, we were sort of just building up a bank of just samples. You can actually use saliva for more immunological studies. We were collecting it because it was easy. But as we started to see virus detection, we saw that there was very comparable detection in the saliva as compared to the nasopharyngeal swab. So this really, knowing all of these challenges that we were facing with the difficulty of the swabs, the risk to the healthcare workers, testing aversion, which we still hear a lot about today, we thought, if we can help validate another sample type, this can just really expand our testing options so that we can just have more options out there and, help increase the access to testing. So there was a little bit of also basis for using saliva as a sample type for SARS-CoV-2 detection. So saliva already is the collection of all oral fluids, so it's just very easy to collect. It's sort of, by collecting a saliva sample, you're sort of sampling many, locations, like many parts of the mouth all at once. Previous research has shown concordance between saliva with nasopharyngeal swabs for the detection of upper respiratory viruses, including other coronaviruses. Healthcare workers are not required to take the samples, as we saw with the nasopharyngeal swab. So this can help reduce transmission. And importantly, it's really practical for efficiently screening a large number of individuals. So, you can hand saliva collection devices or very simple plastic tubes out to a large number of people, have them collect their own samples. So this helps increase sample throughput, so decreasing that waiting time for specimen collection. You can just really get a lot more samples in a shorter period. And I think most importantly for going forward, this just really helps to facilitate frequent and repeated testing like we're seeing is needed in many places today. So with that less discomfort, I mean, here we say patients and healthcare workers, but just for anyone who might be in a screening or surveillance setting, just, again, we're still seeing a lot of aversion to swab-based methods. So this did lead us to the development of Saliva Direct. We received FDA emergency use authorization for Saliva Direct on August 15th, and it has been described as the most unique EUA that the FDA has issued to date. So throughout our work in this, the really main goals that drove our development of Saliva Direct were to reduce testing costs, and this would help us to increase the number of tests in the community, but also to reduce the implementation time for labs, for groups, community groups, to be able to use saliva as a sample type. So the very key points to Saliva Direct that's really important to know is that it's actually just a protocol that we've developed. It's a protocol that we're sharing to other labs that they can use. So it's not a test kit. It's not, it's not something you can just take home and do. We're not packaging anything up. We're not distributing anything ourselves. So we haven't commercialized anything in this. We have no financial interest in this. We're not making anything from this ourselves at all. What we do have the ability, though, is to take this protocol and give it to high complexity, CLIA certified labs. Once these labs have this protocol, they can go direct to the suppliers, they can order the reagents, they can easily get this protocol up and running because we have done all the upfront validation for them. They just need to show that they, can do a small validation with some samples, but then they're ready to go. What's also really important about this is that any updates that we make to our EUA, which I'll touch on later, is that this is then extended to all other authorized labs. So again, this has been a very unique EUA, and I'm not sure how many people have seen in the news recently about the FDA changing its review processes of LDT, so other laboratory tests, and even EUAs. But the FDA has actually stressed, and they've specifically named Saliva Direct as an EUA that they are going to continue to support, they are going to continue to review for us because of this idea that Saliva Direct has such a broad reach that so many labs will be able to pick this up and use it and really increase access to testing rather than, having to develop their own EUA. So I'll just give you a very quick overview of what Saliva Direct is. I mean, it is a very straightforward procedure. We do just take a very simple saliva sample, again, just in a very simple plastic tube. We mix this with an enzyme called proteinase K. Saliva can be a little bit viscous, so this just helps break it down. We heat and activate it, and we still do that PCR detection. So again, we're targeting the primers and probes that have been published and very broadly used all over the country by the CDC, so targeting the viruses N1 and the human RNase P, just as a measure of sample quality control, just to make sure that we have a good sample in there and that you're not getting a false negative result because of an issue with the sample or some sort of inhibition. We obviously had to do a lot of validation for this, and some very key findings that we had along the way is that saliva is stable without preservatives. So there are some very expensive collection devices out there which have buffers or stabilizing agents in them, but these devices can be priced at anywhere from about $7.50 to $50 per collection device, which, if you're doing a mass testing program, will quickly, price that out. So again, we can just use very simple tubes. By removing that RNA extraction, so the longer, more cumbersome step, we have still been able to maintain sensitivity. In fact, we did a comparison assay with some samples the FDA sent out to us all, and they were a range of blinded samples, and we found that Saliva Direct has the same sensitivity as many of the other great PCR tests with RNA extraction out there, including the CDC's own assay. We have the same a limit of detection or sensitivity as them. We have also managed to maintain that sensitivity by combining the PCR test into one rather than doing the 3 separate tests, which was longer and more expensive as well. What's one of the key things about Saliva Direct is that for every step of the way, we've validated different reagents or different instrumentation from different suppliers. We did this for a number of reasons. One of them is to try and circumvent all of those supply chain issues we saw very early on. So if for some reason one of these reagents became under, a really huge demand again, there'll be other options available. We also like to think that by having some different suppliers on there, it keeps competition between the different suppliers to sort of like help keep those prices down rather than just recommending one supplier who then could then put their price up in response to that. And by validating the different instruments, which actually now we've already got other ones, a couple of others onto here, and we've got a list of about another 9 PCR instruments that we're having bridged onto our EUA at present. This means that labs can use what they have. You know, we really wanted to make sure that labs didn't have to go out, buy something new, spend money. All of that, anything that a lab would have to spend to get up and running would have to be passed on to the, you know, to the consumers getting the testing. So we wanted to avoid that. So by doing all this, having this competition, having no RNA extraction, the price per sample for the reagents is between about $1 and $4. I mean, these are list prices. So actually with standard discounts, good relationships with suppliers, reagents alone are about $1. We've had a number of labs come back to us with their cost analyses because, of course, there's other costs on top of this. You know, some of them have said that, you know, with all of their overheads, this might be more like $6 per sample, maybe $10 per sample. We have got labs committed to charging $20, $25 per sample. So this can be comparatively a much cheaper test than some of the others that are out there at the moment. One of the big questions has been, as always, how do these tests work in asymptomatic individuals? So Saliva Direct, like many of the other EUAs out there, is for persons suspected of COVID. It's quite a broad classification. There is only one EUA for asymptomatic individuals. But to be suspected of COVID, you know, that can sort of just be, you know, if you've been in a public setting, if you've been around other people, if you've been traveling. So this can sort of cover anyone who just might need some COVID testing. But of course, how does it work? And, you know, some of those people will still be asymptomatic. So how does this compare to other tests? We were able to do this. We were able to validate Saliva Direct with I think it was 3,800 saliva samples that we got from the National Basketball Association. But what we saw is we found a really high concordance between, they were having a combined nasal and oral swab, and they were having that tested with RNA extraction, PCR detection by some of the big reference labs. And we were testing their saliva sample with Saliva Direct, and we have found that Saliva Direct performed very well in this population, further sort of highlighting to us its potential for screening and surveillance settings. So we have all of the information regarding Saliva Direct available on our website. So if anyone is wanting to look into it further, especially if you're working with labs who are looking to become designated to use Saliva Direct under our authorization, we have all of the details there. We're also going to be listing the labs who become designated. And we also have a link to all of our sort of papers and protocols and results that we're finding along the way. We're very much for open science and all of this. We've been very transparent in everything that we've been doing. Again, really just hoping to be able to get testing more broadly accessible and up and running to make, you know, to really make a difference in local communities who are still struggling to find testing options. So with that, I will end there, and I can hand over to Cheney, who is going to talk more about screening and surveillance in the school setting.
So I wanted to just give a little bit more of an overview on the purpose of surveillance in school settings and why that's something that's really important, and what the difference is between sort of like screening and diagnostic testing. So what testing is what probably most people have gotten already, and that's just, you want to know whether you as an individual, for your own information, have any disease, in this case obviously COVID-19, whereas screening is specifically targeted to groups of individuals who are healthy. They're not specifically suspected of COVID-19, with the two-pronged goals being to identify cases that would otherwise not be noticed and still have the capacity to spread to other people. And in addition, to obtain data on how the virus is spreading in a group of people. So that's the two advantages to having sort of a program that approaches testing everybody in a school, all students and teachers. And so obviously there are a lot of reasons to consider routine screening. And, you know, the number one, all of them sort of center around the idea of trying to keep the schools open and while also keeping students and their families safe. So if you are able to get high participation in a program, that means you can isolate individual cases as you find them, and schools can generally stay open longer, and you can sort of build plans around having students in person in school, not having to, not potentially missing classes because of barriers that remote learning puts in place. It also means that you have a better idea of some community transmission and provide some level of protection for students' families. And it can sort of even help the sort of secondary effect of helping the community at large. And it allows people to continue to work and to keep students going to school. And sort of specific for you guys, it allows you to gather data on how many students are have COVID-19 and what is working, what isn't working. And you can make really data-driven decisions on how to build your plans. And so I think a lot of people have probably seen this. It's kind of been making the rounds on Twitter mostly, but it's sort of like the Swiss cheese model of trying to prevent COVID-19 spread, where we have sort of the different interventions. And so going back to school, that's definitely the goal. So like masking being one, and physical distancing and everything. And what the screening is really doing is it adds another layer in terms of preventing further spread for positive individual cases, but it also lets you know what people are actually sticking to and what is working and what isn't working, and you can modify your school's approach based on that. And so, you know, I'm sure that you guys are running up against these issues as well. And so the reasons that that this isn't available everywhere is not because it's not useful. It's because it's expensive and hard to find labs that can do it. You know, we kind of mentioned here, but I just figured I'd mention quickly that in New Haven, what we're proposing doing is having once a week screening for entire classrooms of people. So that's sort of protects anonymity. We're pooling saliva samples, so that means putting them all together and testing them as a group, protecting anonymity, but that does mean that it's no longer a diagnostic test. So it requires follow-up testing, unlike individual saliva direct testing doesn't require any follow-up confirmatory testing. And the sample collection is done at the school to sort of improve the ease of having the collection, reduce the time commitment it takes, make it really easy on teachers and students and caregivers. It minimizes the time, and because saliva is such a stable sample type, it doesn't require refrigeration, and it can really just be collected in you know, tubes. That saliva based testing is a really good way of going about this, and sort of the approach that we're taking in New Haven is to implement the testing now, and then sort of make decisions based on how well the testing is working, how much it's helping us, and use that information we get from sort of a couple of months of a pilot program to determine whether it's worth sort of the investment it takes. And this is sort of also underscores the idea that testing is something that evolves. There are sort of new generations of tests that can come out, and approaching it in the way of having a pilot program or being open to flexibility allows you to sort of make these real-time decisions as sort of the way the outbreak is happening changes over time and as we learn more. So I figured we could stop and take any questions at this point, but these are a couple sort of frequently asked questions, I suppose. So one of them is like whether screening means that you can relax other measures such as social distancing. And, you know, it's kind of a yes and no answer. You probably shouldn't do that right away, but what testing does is it lets you know whether, you know, people are falling through the cracks. And, you know, if there are classrooms that don't stick to physical distancing, whether they're going to have higher numbers of positive cases. And that, you know, this is where the extra data you get from testing really helps you make better decisions down the line. And then we keep learning more about this virus, how it spreads, how to prevent it. And one of the reasons is because of really strong screening programs. Another is whether testing should be opt-in or mandatory. You know, all I want to say on this is that, you know, high participation. So if you you know, high % of the people who are in school are getting tested, that means you can sort of have more precise interventions. So if everyone in a school is getting tested and you have 2 positive tests, you only need to send home, you know, 1 or 2 classrooms. But if not that many, if half the people are getting tested, you might not know how many actual cases there are. So you might need to shut down a whole grade or, you know, close down an entire school for a while. So, you know, there are ways of trying to encourage participation without making it mandatory. So providing, you know, accurate information to parents and their families, using non-invasive testing techniques such as saliva, and, you know, doing the collection at school right at the beginning of the school day, making it as easy as possible and being as transparent as possible about the testing program. You can get high participation even if it's opt-in testing. I think now is a good time to sort of pause for any questions about Saliva Direct or about screening sort of in general. And thank you for letting us talk about this. I'm really glad to be able to sort of give back to the school that, you know, made me, so.
It's wonderful to have you back, Janie. Melissa, was there anything else that you wanted to say before I open up to the board to ask some questions of Dr. Wiley and Cheney?
No, I think actually she covered all of the questions that I had, so thank you.
Well, you can reserve your right, of course, at any time to raise questions. Well, then let me throw it open to board members, and Dr. Wiley and Cheney, I'll call on board members to see if they have questions or comments for you. A lot to digest. We're learning as quickly as we can here. So with that, why don't I just see who wants to go first? Nobody wanting to go first. Ted, would you like to ask any questions or comments for our guest?
I don't have any right off the top of my head.
We'll wait to see where the conversation goes. That's how this typically works. Mr. Guzman, would you like to ask a question of our guest?
Yeah. Thank you both for the information. That was really good. I had 2 questions, and one of them was already addressed. I had a question about this testing environment, if it had to be collected in a controlled environment, but it sounds like that you can just do it at the school. But for people when they're being tested or collecting this saliva, are there any pre-test requirements, like not eating or drinking? What are any time frame before the last meal and the test, anything like that?
We do recommend that you don't eat, drink, dental hygiene, anything like that, preferably for half an hour before the test. We do at the most say like maybe no water for 10 minutes before the test. in saying that, we have received a vast number of interesting saliva samples throughout our work so far, and even though we received almost every color of the rainbow from the NBA, we only had a handful of samples that came back as invalid. So it was something like 0.1% of samples were invalid, which, immediately, if you've got an RP negative, that's why we have that human control in there, you at least know that it's invalid. So you can say, well, there's two things. If this was an individual test, you would actually be able to flag that individual for a follow-up sample or just know that they hadn't been properly tested at that time. However, if you're pooling, what we actually find is that you get, if there is something that has something inhibitory in there, once you put it into a pool, the rest of the samples dilute that down. And we've actually seen better detection of positive samples when they're in pools with other saliva samples, because it does work through anything that is potentially inhibitory.
Guillermo, you good? Yeah, okay, good. Thank you. Thank you very much. Julie, do you have any questions for Dr. Wiley or Cheney?
I do actually. I guess either of you can answer, but it was from a comment that Cheney made. Cheney, welcome back. Thanks for talking to us tonight. Do you guys have a suggestion on whether we would start with individual screening or a pool screening? And at what point do you decide is there like a time where you would switch back and forth? What are kind of the metrics of that? I guess that's my question.
Great.
Yeah, so there is a sort of argument for switching back and forth. So sort of an intuitive answer is if there's a high incidence. So if a lot of people are testing positive, pooling testing, because you have to then do follow-ups to find the individuals that are positive, you can't pool as many samples together. So like if there's a high peak, so like there are more cases, pooling becomes less effective. But in terms of how to start out, that really depends on what your lab's testing capacities are. Pooling kind of requires some experimentation and working with the samples and developing an approach for that. So it sounds like you guys are kind of investigating a few different options for testing already. So in terms of what would be the best sort of first step, getting screening in as soon as possible, to be honest, especially as cases are rising around the country, is a really important step to take. And in terms of, and that's sort of another pro of taking sort of a pilot program approach, is that, as testing can become cheaper, or as you develop pooling approaches, you can then potentially bring prices down the line. And I don't know, Anne, if you have anything to add to that. I think you did the actual pooling experiments, so.
Yeah, no, exactly what Cheney said. And I mean, indeed, especially it's the two things, prevalence and how that's, going to affect positivity rate. I mean, it's definitely something to consider, especially if cases are under control, you have very low prevalence rate. If it means that you can be, doing much larger pools down the line as a way of continuing testing so that you can nip any outbreaks early in the bud, that's something that's definitely worth considering. But indeed, just working with the labs. And, if in the end, I mean, some of them have come back and said that they can do some of these tests cheap enough that, by the time they do the pooling, maybe they'll be able to do an individual test similar to a pool test anyway. So again, depending on what the labs have to offer and what they can do.
Good.
Can I keep going?
Yeah, Julie, please,
Okay.
go ahead. Yeah.
So would it be safe or would it be fair to say you might suggest starting with individual tests, and then depending on how the numbers look, if they're high, obviously you're going to need to continue that, but if they're low, maybe you can start pooling. Is that a fair assessment?
Yeah, it is. And sorry, Cheney.
Yeah, I'm just nodding. Yeah.
Yeah. And I mean, there's ways of doing this that we can also there's actually some great, there's actually like a little widgety thing online where you can be like, hey, if this is our local prevalence at the moment, and this is how the tests are, this is what we pull. And you can actually sort of find that sweet number about what's sort of a recommended pool size in terms of how often you'd have to retest. So there's little things like that that can help sort of inform those decisions as well.
And then I just have one more question, unless I have a follow-up question.
Yeah, and you're entitled to ask it if you do, Ms. Hill.
So my other question is, where do people usually do these? And I don't know if there's even a usually yet. Where do they usually do these samples? Like, where are people taking the tubes home? Would you do this like standing outside the school? Is it like in a nurse's office? Like how does this generally work? Or do you even know yet because it's too new to even say?
Yeah, kind of just yes. Any of the above. Yeah.
Whatever we decide would kind of be the answer then.
Mm-hmm.
Okay.
And just a
Yeah.
and it might also, just from our experiences, that might just come down to whatever the board or the teachers or the school is comfortable with as well, just in terms of like, some places are very comfortable with just having the tubes at home. The kids can produce their samples easily before they come in, and it's a very simple drop off. You have other situations where the community feels more comfortable having the kids take the samples at school, just so that you can be really sure that it comes from that individual. But this is all sort of up to sort of the individual school preferences as to what might work better for them.
Okay. Thank you. That's all I have for now.
Wonderful.
Thank you both.
Thank you, Julie. Ms. Buttermore, questions for our guests?
I do. So I think you said the range for the test you've seen is $6 to $25. I guess what is the highest cost that you've seen?
Well, to be honest, one of the highest costs that I saw was when we first started at the Yale Pathology Lab, where it came out at $59 a test. But their thing was that they were setting up brand new with this test. They're having to get the staff to do it. They didn't know, they was expecting very small numbers to begin with. And they even said that they'd probably bring that price down. And they have brought that down now that they're up and running. They've figured their system out. They've got their equipment online. They're charging $25 per test. It's for Saliva Direct, it's an amazing community that we've experienced so far. So we do actually host calls twice a week with labs who are getting up and running. And the question on price comes up. And actually, there was a lab who was trying to charge $135 a test. And this conversation appeared on our call last week. And I stressed again what the mission of Saliva Direct has been: to get accessible, affordable testing, have it as an option that's out there, explained Yale Pathology. That lab came back to me immediately after that call and said that they are dropping their price to the $25 that Yale is doing. So we're hoping that, we're trying to pass on our mission and hoping that other labs will take that on as well. We're also just hoping, and what we're trying to encourage some labs to do, or that we partner with, maybe there are ways. We've heard some, there's some labs that have quite a lucrative contract with some companies who are prepared to spend a lot for testing, but then the labs are then able to maybe perhaps help supplement, more vulnerable communities to help test in another way like that. So we've sort of seen we've heard discussions of that happening, to be able to then offer a more affordable testing to the likes of schools and community groups.
And so I'm assuming that price per test is when you're doing individual testing. Would it be that if you pooled it, it would be, say, the $25, or when you're pooling it, is it a more expensive test?
So what we've been working, I don't know who's heard of Miramis Labs in New York, but they've done an incredible job with pool testing. And it's sort of, she's a mother herself who's just desperate to be able to get her kids back to school, and has just taken it on herself to have pretty much, as much testing in New York schools as possible. And they're doing pool testing where I think it's 24 samples per pool. And then with the reflex test of Saliva Direct, if there's a positive in there. So they're doing it, they really started out as surveillance. So it was really, if you look at salivaclear.org, it explains it. So at first it was, they do these pools of 24, then they got down to groups of 2. So they can still sort of, keep sort of anonymity a bit so they can do surveillance, but helps you sort of identify maybe where that positive test is coming from. They're now doing reflex testing with Saliva Direct to actually confirm that. And that works out to $12 per sample. So, they're hoping to sort of share their model and also get that out there.
Okay. And I feel like I had one more. No, that's it, I think, unless
Yeah,
I come
you
up
good
with
for
another
now?
one later.
Okay.
Thank you very much, appreciate it.
Thank you. And Mr. Lobach, questions?
Yeah, and I think that I probably missed something at the beginning, and so it's going to sound like like a silly question, I guess. But what are the benefits over pool testing over individual testing of that same group in the pool?
So, so the benefits of pool testing is if you can get it, just if it makes it more affordable. If it means that you can actually test more of your population more often, or that you can have your testing program prolonged, that's where pool testing might be more useful. Also, if you're using it as a surveillance test, so you know, there's a way to, I mean, sometimes there's also been talk of like some schools, just to make it even easier, you might do the girls versus boys, but then there's also been talk about, you know, maybe you don't want to be like, hey, the girls, someone in the girls has it, someone in the boys has it, but some other way of sort of doing that. So you can maybe bring it down to smaller than class level. But if again, it really comes down to the community that you're working with, and if they, you know, do you want to identify particular individuals as definitely being positive, or do you want to be like, hey, someone in your class has tested positive, we, you know, recommend that, you know, your families go and get tested or something like that, or do we do, you know, a smaller group within that class, so we can just like, you know, maybe notify 5 families that maybe they should consider going to get tested. So yeah, pooled is good for price, but it's also good for, as Cheney really highlighted, that anonymity. At least with individual testing, or at least the reflex testing, you can really get to, you know, who that is. But we understand that that doesn't work with, you know, concerns in every community.
I guess then to follow up on that, so if the pool testing identifies X number of individuals in that pool to be positive, is the follow-up testing that's recommended, is that done through this same program as an individual test, or is it going to an outside lab and then waiting 2 weeks?
No, so it's going through the same lab.
Okay.
Yeah, so they can have the same sample. You don't need to retest everyone. So it's 2 things. So if you're working with a lab who can do that reflex testing for you, whereas if it's more like, hey, we need to notify this family, they have to go and get their own test, then you might run into that problem. But then maybe you have that contract with the lab so that those families can go to that same lab. Again, it comes down to like how you're identifying the individuals in the pool and how anonymous or not you're making it. But ideally, yeah, if you could have it just rerun at the same lab, that would obviously be very helpful for everyone.
Okay. I think that's all I have for now,
Okay, well, good.
I think.
No, that's all right. We're learning.
Thank you.
We're learning. Thank you.
It might
So-
be even, sorry, just to like,
Oh, please, Ann, go ahead.
so there might even be ways that you can build that into like the price schedule or something, because you could also make it that, you know, if there were
That would
any
make
other
sense.
barriers to individual families testing positive, and then, you know, if they felt, hey, I don't know if I want to spend that, or I can't afford it, or do I have health insurance, it's like, hey, we need to do individual testing, but that's covered in the price structure of what we have already established anyway, so you can get covered by that somehow.
And that makes sense. Thanks.
Okay, thank you. A couple of questions, Ann and Cheney. And I think I'm looking at, or recently looked at a paper from Yale that you may have all been listed on, that I found very interesting, and it seemed relatively current. And it spoke to the importance of testing a patient at different stages of the infection. And so I thought that sounded really important. And so obviously this is about saliva testing. So can you talk a little bit about the importance of the stage in which you identify that, particularly an asymptomatic person, a student or a staff member, would have the infection, but would not necessarily at that point be infectious, but would be shortly? Or I don't know if I'm framing that in exactly the right way, but you certainly made the paper seem really important. So, and it seemed important to us. So can you speak to the testing at the stage of the infection, particularly with asymptomatic students?
Sure. So what we ended up finding was that, first of all, it varies from person to person quite a bit, but for the most part, people can be detected within, sorry, I'm just making sure I don't have the numbers wrong. So I have the paper pulled up on my other screen. But people can be detected within about 2 days. And they test positive through Saliva Direct between days like 2 to 5. And I think that was sort of, this is for asymptomatic individuals. So this is sort of the key takeaway in terms of a screening surveillance program. And I don't know if that more or less answers your question. But yeah, well, I mean, this was again with the MBA cohort, and we just, because they have sort of like repeated testing on multiple days, we were able to get sort of the last negative test and figure out exactly, based on sort of case tracking, where when they got infected. And so we were able to sort of figure out from the day they got infected, when did they start testing positive and when did they stop testing positive. And more or less, you start testing positive around day 2, 3-ish. And then when you stop testing positive can vary quite a bit. But, and I don't know if you have anything really to add to that.
Yeah, no, it's definitely been a hot topic of conversation throughout all of this. And I think, yeah, the study that was done has helped, you know, if for so long we were detecting just positive or symptomatic individuals. And there's sort of this understanding that indeed PCR testing gives you the ability to maybe catch someone 2 to 4 days before they become symptomatic, which is, of course, you know, it's sort of that rise as they're becoming symptomatic when they become infectious or contagious. So if you're able to get them sort of that 2 days before that point, and you're able to isolate them and actually, again, stop transmission, that's what can also just really help sort of prevent further outbreaks, or even just, you know, even help contact trace, you know, if you can then sort of go back and know who to more selectively test.
Yeah, because there's like a smaller window then for all the contact tracing you need to be doing.
Okay. And so related to that, is more frequent testing. I don't know whether it was one of your papers or something else that looked at a chart that showed layers of protection or the ability to reduce the spread of infections, that there was a benefit in doing it once a week. But then when you got to twice a week or every 3 days, it seemed to dramatically improve. If I'm reading the chart right, and I might not be, dramatically improve the ability to contain, to capture, to restrict the infection. Is that correct? And does that apply also to young learners like K through 5th grade? And does that change as you get into elementary school or high school? Can you talk about that a bit?
Yeah, so you're kind of asking the same questions that all the scientists are asking. So again, it's really so a lot of that is still to be determined. But I will say that, you know, you still get the data benefits. So like the understanding of how many people are positive as a group on a given day, whether you do it on a weekly basis versus a daily basis. You still get the benefit of the data, but again, you don't necessarily get the benefit of being able to contain the cases as quickly. I don't know necessarily that I don't think I know the paper that you're specifically looking at, but yeah, Anne, do you know, Anne was more involved in developing the New Haven Public School program than I was, so.
So I think generally, you know, a lot of it, we spent most of the summer sort of advising different schools, colleges, everything, and they sort of return to school strategies or what could possibly be done. And, you know, I think ideally, especially for the colleges though, it was, you know, if you couldn't do twice per week testing, you shouldn't be considering doing this anyway. But the thing is that especially more for K through 12, we know that there can be, or even some of the colleges, the budgets are very, very different. And you know, even if you can have once per week testing, as Jenny and I sort of mentioned, you know, you might have this only 2 to 4 day period before an individual becomes symptomatic. So if you're only testing once per week, chances are you could miss someone. They could come up, you know, a couple of days later and you could have that going on. But still the fact is that you've got testing. So you are still going to be able to pick them up the next time or sort of capture that if needed, or if you do need to do like an emergency outbreak sort of response, you know, you've got the lab that you're working with that you can probably be like, hey, here's some samples for you. So, I mean, the NBA again showed bizarrely that they've like taught us so much about public health in the last season. But, you know, they showed that testing every 2 days was fantastic for preventing the outbreaks. I must say I was very hesitant about Yale bringing students back from all over the country and what we might see. They're only testing their students twice per week. And, you know, we've had one outbreak recently, but again, because their cases were so under controlled, it was so easy to contact trace, isolate, follow up testing. There is that key conversation about K through 12 and the risk of transmission in children. I mean, we all have sort of heard that at least infection symptoms, illness in children is less. But I mean, I can say that a child in my friend's child's daycare tested positive the other day and sort of shut the daycare down. So I mean, these cases do happen, and maybe these kids aren't going to be symptomatic, but again, they're also telling you sort of what's going on in the community. You know, they're serving as a proxy for what's happening. And, you know, if they've got a viral load that's easy enough to detect, chances are they're probably still able to transmit that between each other, even if they're not getting sick. And that can mean taking it home to their families and even older children who are then more likely to get sick. So, you know, I feel that, you know, maybe there is slightly less transmission in K through 12. So maybe that once per week, and again, better than nothing. Again, you don't want it to give people a false sense of security. I think that was the question about the whole, you know, can you relax other measures? I mean, it can give you some like certainty or reassurance, but, you know, or it's even like, you know, you have everyone tested on Monday. They have all results. Everyone's clear on Tuesday. Chances are, because none of them, you know, your pools didn't test positive, Tuesday and Wednesday, you're probably in this quite this like safe little zone to maybe, you know, maybe relax social distancing for a little while because you know everyone the day before tested negative. Maybe as you're coming up to Thursday and Friday where you know that you've moved further away from that negative test, that Thursday and Friday you start doing things a little bit more distanced again, a little bit more outside, maybe a little bit more remote, and then you can come back after the weekend and test again. And then maybe there's sort of strategies like that you can take to help inform the format that classes or programming can take throughout the week as well.
Okay. And does a positive test through Saliva Direct, does it require a confirmation test?
No, so we do have EUA as a diagnostic test. So it's done in a clear laboratory. It is a diagnostic test.
Okay. Okay. And speaking of tests in the labs, to do this test, does it require specific machinery, PCR machines to do it?
Yes, it requires a qPCR, RT-qPCR machine, yeah.
Okay, so I have one last question that's related to the testing, and I really appreciate your taking the time to educate us. The board was also provided with some information about, and I'm only going to pronounce the initials, but RT LAMP, L-A-M-P, and there is a bit of that screening that's happening in Illinois, and it seems to be getting positive results. Can you talk a little bit about how the Saliva Direct test, and I guess the Illinois Shield test also, is different than the RT LAMP test? I believe they're both PCR tests, am I correct? Or, and if they're not, how are they not? Maybe they're not, but they're kind of sort of are. So anyway, so there you go. I only know enough to be dangerous. Go ahead.
So I had never come across, I had only heard a mention of LAMP before coming into, actually, Tony, do you know it better any by chance than I do, or?
Yeah, I think in terms of what it actually means for testing, the LAMP test, it would require confirmatory testing. So you can't then go back and tell someone you have COVID. Sometimes you can get around that by strongly suggesting they go get tested, and say, or telling them that you came back with the LAMP positive. The advantage, so that's sort of the downside to the RT LAMP test. The advantage being, so Saliva Direct and all diagnostic assays so far require a high complexity CLIA lab. So that means it has to be done in a very fancy lab with people who have, certifications specifically to be allowed to run these tests, and the lab has to be certified to run it and everything. That tests that aren't diagnostic tests don't necessarily need that, which means they don't have to pay as much for facilities, and they don't have to pay as much for these highly trained people to run it. So I think that that's sort of a good comparison. Probably in terms of pricing, I couldn't really give you a ballpark, but getting a quote would be a good idea. And another important question to ask is whether the LAMP testing uses nasopharyngeal swabs, or what kind of swab it uses, because a lot of the time, if it's an NP swab, you need a skilled healthcare professional to give that. Whereas with saliva, you really don't need anybody with training to do that. So that's, that's separate from the LAMP versus CLIA thing, but it's another question that you'd want to be asking of any test that you're getting.
And so I have sort of dabbled in it a bit. I mean, we knew from, we didn't see Saliva Direct to be the be all and end all of testing either. We went a little bit the path of least resistance with the FDA by taking the PCR approach, but it is something that we've been very aware of, is like shifting to a LAMP back end ourselves. And so these other assays that were out there, there are some good papers showing the comparative sensitivity of LAMP versus PCR testing. And some of them are doing a really good job. So the idea that, as exactly as Chang said, that you can actually potentially move away from the restriction of a clear lab, which can help bring those prices down. And it can sometimes help, I've seen the really great, actually it's from the University of Michigan. It's one of the universities, and they show all the outdoor testing that they're sort of able to do on the spot and have the little makeshift labs, because they just need like a thermocycler to heat the samples and look for the color change. So it definitely can be used as a good option for screening and surveillance, especially if by any chance it's a cheaper option. And again, if it allows you then to at least have a testing program or more frequent testing, I think it's definitely worth exploring.
Okay, well, thank you. Thank you. I appreciate you taking the time to answer those questions. Board, any final questions that might have gotten triggered from the conversation? Jessica.
So if you had enough money to do either individual tests once a week or pooled testing twice a week, where would you put your funds?
On the spot.
Maybe pooled testing twice a week. Wait, did you say individual once a week and pooled twice a week? Yeah. Yeah, I would almost say pooled twice a week, just because, as I said, you have that longer window of, or again, maybe it's also, as Cheney also introduced, a more of a reactive kind of thing. So if you're starting off with a higher prevalence, maybe you want to do pooled twice a week just so that you can test more of the population more often. And as I said, there's that smaller window of when people might actually start testing positive. So if you're testing twice a week, you have a more chance of detecting more people earlier on, versus just that once per week testing. You might then sort of move to a spot where maybe you go down to once per week for everyone, and then you might even just end up going to once a week pooled testing as cases really drop off. So I think that would be, I don't know if Amy, have you got any other thoughts on that?
I agree. I think frequency in testing is really important. It's you're really kind of balancing the frequency with, obviously with the cost and with the sensitivity. And I think that it's a tough balance to strike, but I agree. I think that in this sense where the sensitivity would be the same, it would be better to do pooled testing, probably do pooled testing a week, depending on the prevalence.
Okay, and then in the example that you provided with the New Haven district, where it was once per week pooled by class, what was the rate, what's the rate of spread in that community? Are you guys, is that district in the red when that plan was made, or moderate spread? Everybody defines it differently.
I mean, Connecticut's been very, I mean, we had been doing a very good job until recently again, and now we've joined everyone else back in the red. So it was definitely more developed, but again, it also just came down to budget. And again, the idea that so far it's been a push to try and even have once per week testing on the table. And at least if we can still be at least once per week testing, that's better than no testing. So yeah.
I think that's it for me. And Cheney, it's nice to see you in the flesh. I follow your mom on social media, so I've seen lots of posts. A very proud mom and lots of impressive things happening. So thank you for coming here.
Let me go around one more time and give every board members one last chance before we let you go. Mr. Estes, any follow-up questions?
No.
Very good. Guillermo, any last questions?
No, thank you.
Thank you. Julie?
I do, sorry.
No apologies needed.
I guess this, I'm going to assume the answer is yes, but does this disease, is it detectable? I'm trying to put my question into words. I'm having a hard time doing it. Is this test as valid with children as it is with adults? Like, is this, I assume you have tested this on a wide swath of population of ages. Do you find any difference in how effective it is with children versus adults, or is it the same? Or
To be honest, we haven't tested it on children. And actually, I think a lot of it is that many of these tests haven't been. There's a couple of things to think about. First of all, I mean, so much energy and time was put into responding to the pandemic when it started, and now it has been very much on the forefront of our mind. I guess, okay, there are a couple of things in support. Obviously, Miramis is doing an incredible job testing schools all over New York with pooled testing and reflex testing of Saliva Direct. So actually, yes, they are doing an incredible job. That works. And I think one of the big questions that often comes up as well is that it's also should just do with a viral load. So this is like these questions where it's like, you know, is it symptomatic? Is it asymptomatic? Children, adults, that in the end, it's the presence and that amount of virus that's in the individual that you're detecting. And it is just like a standard cutoff in every individual, like regardless of who they are, how old they are, symptoms or not, there's that sort of lower limit of detection you're going to hit with how many copies of virus it can pack up. You know, I really hope that the fact that Miramis is doing a fantastic job and that, you know, that's the model that New Haven is going to be continuing as well, I think is hopefully evidence that, you know, this approach is working in those populations. I don't know why that sort of escaped my mind to begin with, but yeah.
thanks.
Okay. And Mr. Lobach?
So was your answer the test had not been used on children?
But I
It
was
is being
thinking of,
used in
Okay.
New York.
All right, I'm like,
Yeah.
I thought I missed. I'm like, I had to have misheard that. Okay.
No,
Okay.
no, I was thinking like of
no.
cohort
Thank
studies. I'm sorry, but no, I just only realized that I was completely like, it's like, oh yeah, but that's exactly what Miramis is doing. It's just in all the schools in New York. So I'm really
That's
sorry about the
like,
confusion.
very confused. I get in my head sometimes too, so I understand that that happens.
Okay. Well, I have no additional questions. Dr. Kaskowski, any question?
No, I think they've covered everything that I had written down to ask.
Very good. Well, Ann, Dr. Wiley, thank you for giving us the time. Thanks for the life's work that you're doing. And please pass our regards to Dr. Guba to continue this great work. And Cheney, I got to tell you, there's a lot of pride in this room having you on this call and doing this work. And it's great to see that you took your D41 education and you decided to put it to work serving the public good. So please keep doing that great work. I'm counting all the papers you have your name on, and I'm beginning to lose count.
I just think it's hard for him to count that.
And you got up to a pretty high number. So keep doing the great work. Thank you both very, very much. Good
Thank you
night.
for having me.
Thank you.
And thank you all for working so hard to keep the schools safe. So.
Yeah, and if there's any other questions, don't hesitate to reach out. I mean, if anyone's even interested in joining any of our calls that they're for labs, but if it's more of just like an information gathering, or you wanted to sort of direct any labs to listen in, or anyone else you think that might be useful for, you're welcome to do that. So, and we're here to help as many people as possible, just with, anything that we can do during this.
Thank you. We'll do that.
Thank you.
Good night.
Thank you both.
Good night. Okay, we will now move to our board reports. And keep in mind, board members, you all have to be as insightful and as brilliant in your board reports as Dr. Welly and Cheney were in their presentations. That's a hard act to follow, but here, let's give it a shot. Mr. Estes, any board reports this evening?
Yeah, I have one, and give me just a second to pull it up, and I'll be really quick. I attended the Abraham Lincoln PTA meeting last week. I won't necessarily read my notes. Anybody who's interested can take a look at the notes. But I was impressed that they're busy working on various virtual engagement activities for the students. There was a Pro Kids Magic Show virtual assembly that was well attended recently, and they've got a really cool sounding one coming up for January, but I don't want to talk about it in case it's a surprise.
Okay.
But I kind of want to participate. They had a move-a-thon fundraiser. They were a little under goal on that, but it still was pretty well attended with participants. They're looking at other fundraiser ideas. Membership is lower than historically, and they count on membership fees in order to be able to fund programs. So please join so that they can continue these programs and not have to slash things out of the budget this year. And so far, they've sponsored 2 staff appreciation luncheons as well.
Great.
So things are they're accommodating and making adjustments given the current situation.
Yeah, good. Thank you.
Yeah.
Thank you, Ted. Thank you, Ted. Guillermo, any board reports this evening from you?
Yeah, I have a board report just to follow up on Ted's comment. So I attended the Halley PTA meeting, actually 2 of them, one on October 1st and one on the 20th. One of the things they actually obviously talk about is the fund committees. Because of the situation, they're struggling with some ideas and how do we go about this? How can we recreate some of these programs that we're doing virtually? And getting the kids together as well. So one of these things that I thought was a great idea, and I put on my notes and you guys can read it, is thinking about trying to do some community work, some community type of service with the kids to bring them together now that we don't have, the after school parties and things like that. I thought that was a really good idea. As far as the funds, they are rolling out the Halley Magazine Drive that will start on November 11th. They show a couple of pictures of the catalog. It looks really good. A lot of nice things that can be used for Christmas presents and things like that. And the kids will benefit from that. I think they'll get a gift card from the magazine. And they're also finalizing the details of the spirit wear. So they're trying to be creative. Again, just like Ted mentioned, they are short on membership. That drives a lot of their budget. And they're, anything that people can do to get involved, that would be great. The other thing that was really neat during the second meeting, they used one of the tools that we actually provided for the schools. It's called Peer Deck. It's actually an interactive presentation tool where the kids can actually provide answers, and they had videos and things like that. And it's actually pretty neat. They use it during the presentation. It was really cool how we were able to ask questions, and it's been really good for the teachers to keep the kids involved and engaged during the classes. And they were very happy that they actually have access to the type of tools. So they say thank you to the board and the administration for providing those type of tools. And they're also working on this proactive behavior incentive. It's called PBIS. It's a rewards motivation type of program for the kids. They earn points that they can use towards things like gift cards and things like that. And anytime you do some sort of positive type of behavior, it's really good for the kids. They get excited about it, and it's proven to be very positive for the school as well.
Wonderful. Thank you. Thank you very much, Guillermo. Julie, any board report? for this
I
evening?
do have a couple, actually. I attended the first discussion on the resolutions on October 21st, and I'm sorry, I just now realized I should have written that up, so I will do that and get that turned in. As I sat here, I was like, whoops. It was like 2.5 hours, and at the normal delegate, non-COVID, delegate assembly, there, as you discuss them, people line up at least last year, it was like 2 microphones and there's a line and people just talk until someone calls the question. Well, in this situation, there was no ability to call the question. And so you just had to listen until people were done talking. So I did have an opportunity to present our resolution and advocate for it and tell people why I think it's a good idea. And the people did the talking. But I will say that a whole bunch of, especially Chicago Metro districts, were enthusiastically supportive of it. So that was really exciting. We did have a couple whose towns I didn't recognize, so I don't think they're Chicago Metro or where I grew up in Central Illinois. But they were not thrilled about it. But this is the way any resolution goes. But I was encouraged to hear so many support with only a couple doubters. So I thought that was really exciting. So I will do that again on November 5th. And there were like 90, I wrote it down, but I don't know. Oh, 91 participants, because you can see on the Zoom call. So there were a lot of people there. So we'll do this again on November 5th, and then the real delegate assembly will be, I can't remember, the 14th or something. But Mrs. Moak registered me. I will be there to do the work, and we'll talk more about these things later. But I wanted to let you know that I thought that was really exciting, that so many people like, how would you not support this? This is a great idea. Why haven't we done, So I was like, yes,
Nice to hear.
big win for the day, even if it was 2.5 hours on Zoom. And I also attended a PTA meeting on October 20th, which I don't know what day it is. I think it was a week ago, maybe. Some highlights. The literary pumpkins were due today. They were doing all that virtually. Usually they line them up in the library at Ben Franklin, and the kids can go look at them and everything. Unfortunately, we have to miss out on that fun this year. But I have 2 girls at Ben Franklin, and they both took pictures with their Chromebooks and submitted them. And I was like, how do you do this? So those will be coming out soon. I can't remember when they will show them to us, but hopefully they've been submitted. If you're watching and you haven't done it yet, you can still do it tonight. Send Bears Biz for the information. Virtual book fairs are coming. Again, we can't go in person, but you will be able to order online. Spiritware is available until October 30th on Member Hub. And Picture Retake Day is announced for November 12th. So just sign up by the 11th. So I think those are the highlights. I think I had one other, but maybe not. So I'll give up my
Very good.
podium here.
Thank you. Thank you, Julie. Okay. Jessica.
I attended the LEND meeting on Friday, the 23rd, and there was a guest speaker to talk about the state of Illinois finances. And as you can imagine, COVID has resulted in a loss of revenue for the state and more debt, putting our state one step away from junk bond status, which is bad news. So some things to watch for in 2021 in terms of school districts is that there's a potential for a shortfall in the evidence-based funding and or delayed payments. And watch to see if there's a shift of pension costs towards districts. There would be motivation to do that, to reduce costs for the state. And there's a recommendation to work with our state legislators to find balanced solutions. So just some things to keep an eye on, a few more notes in my report, and a bill to kind of everyone to look out for that LEND is working with the authors of House Bill 5851, and it's the Inclusive American History, which has been brought forward by the Black Caucus. And the idea is to rethink how history is taught in our schools. So Lend is working to make sure that's not overly burdensome. And it is going to be a heavy lift in terms of the fact that that will require that the standards that are set for history are sort of reimagined. So it's a big project. So those that are supportive of that effort or otherwise might want to look into that House bill to see the progress and what the Black Caucus is doing. I also attended the SPAC meeting on Thursday, the 22nd, and it's a very supportive community, and that was their first meeting, so it was good to rejoin the group and get some support and camaraderie around how hard all of this is, and it's hard for everyone. But the group is very much looking forward to the opportunity to do more of a Q&A session with the administration and the SPAC members. They very much appreciate the willingness to bring folks together to create a shared understanding of all the barriers that we're facing and partner in problem solving with parents. I just wanted to give out a shout out to Principal Jeff Burke at Brown Franklin. His ears may have been burning while we were meeting because so many wonderful things were said about him, that he's awesome, empathetic, on top of it, that he will help you and get it done, that he's ethical, and someone who just notices when you need support and offers it. So kudos to Principal Burke.
Nice.
I also attended on Wednesday, it's a busy week, D41 Kids Foundation meeting. We have a room on the broom scarecrow in the row of scarecrows in downtown Glen Ellyn, so check that out. It's pretty impressive. Our board member, Colleen Heineman, is very creative and artistic, and former art teacher, did a great job on that. D41 Kids will be with the help and the sponsorship of Saylor and Murphy Orthodontics, providing water bottles to District 41 for when kids are in person, to make sure that everyone has a clean container since there are no more water fountains. We're working with the district in the thermometer and hand sanitizer drive, and want to give special thanks to Marvelous Mind for donating a bunch of hand sanitizer for that. There's some grant opportunities that we're looking at, and there will be a fundraiser coming up before the end of the year. So look out for something really cool that will be fun for everyone, give everyone something to look forward to for the coming year. And then please mark your calendars for Thursday, November 5th at 7 p.m. There will be the Glenbard Parent Series event on mindfulness and self-compassion tools for your mental health. And it's my daughter's birthday that day, so I probably can't make it, but I highly recommend it. Every time I go to one of these events, I take things away that are helpful. And this is the best time to be working on your mindfulness and self-compassion strategies, because things are hard right now. And I think I might have missed a couple of meetings in there, but that's all I have. So
That's quite a bit. Thank you, Jess. And Jason.
Yeah, and I attended the PTA council meeting for a bit on October 20th, 2020. I wasn't there for the entire meeting, and I'm listening there for a little bit more. So when I was in attendance, Dr. K talked a bit about the district's COVID protocols and the mitigation efforts that are ongoing, and I just piped in with reiteration of that, controlling this pandemic is a part of all public concern, and to keep our schools open, it really takes a community effort of mask wearing, social distancing, hand washing, and it's not just our students, it's not just our parents, it needs to be a community effort as a whole. Yeah, and then after that, I had to hop off. So, did I miss anything at the meeting while you were there, Melissa?
Nope.
Okay. And their next meeting is coming up in November 12th, I believe.
Thank you, Jason. In closing, I just want to note that I was able to attend the CIT meeting. Like Jason, I was there for the first half of it, and and Melissa did a wonderful job also talking about the mitigation efforts and talking about the possibility of doing surveillance testing. And I did want to thank Katie Aducci from our Pratt team who joined us for that meeting to speak a bit and to introduce herself to that wonderful team. So Katie, thank you for attending that meeting. Okay, thank you, board. Members of the public who wish to address the board should check in with Mrs. Moak, the board recording secretary. Speakers are asked to maintain respectful decorum and limit comments to 3 minutes or less. Mrs. Moak, is there anyone who would like to make public comment? There is no one. Thank you. We'll move on to our discussion items. And the first one up is the 5-year capital project plan. And Mr. DePorter, apparently you're facilitating this report and discussion.
Yes. So as you guys will recall, this is an annual board report we bring to you about this time of year each year, where we go through and update the board on our planning for the coming summer. So the summer of 2021 and the capital projects that we have slated to be completed. One thing I would note that's a little unique about this go around is we have made a conscious effort to minimize the disruptions to school buildings during the summer, just out of that outside chance that we may need those buildings. Should we have the opportunity to bring children in that maybe need some time over the summer. So there was an effort to keep the buildings open and available during the summer. So you'll see when you look at the attached capital plan, which shows the projects slated for next year, there's 2 projects we have slated. It's the roof at Forest Glen, as well as some interior work for 3 classrooms. So that is the one exception to what I just noted a second ago, is we do need to do some unit vet work and some updating in those classrooms. So those are the only 2 slated for the summer. As you can also see, it's roughly 50% what we just spent in 2020. And that really is in line with what we've been talking about the last several years. And namely that, after we were done catching up with the more critical health, life, safety needs in the buildings, which we've done the last several summers, we did expect to see our annual spend drop closer to that 1.5 per year, whereas it's been north of 2 million the last couple summers. So not only next summer is it slated for around, I think the specific number is 1,465,000, but the following 4 years are also right around that $1.5 million mark. So it is, we were hoping to see, and it does help us to level out our spending moving forward. Dave, anything I didn't mention you'd like to add to that?
No, I think that was pretty good summary.
Okay. So as with each year, we bring this to you tonight just to kind of update you on the plan. We will bring it back for board approval to be incorporated into the budget for next year, as well as to start planning those projects for the summer of 21 at our next business meeting at the end of November. So with that, happy to answer any questions.
Okay, let me go around the board and see if there are any questions that board members would like to ask. Jessica shaking her head no. Guillermo, do you have any questions you'd like to ask Eric?
Just a quick question, Eric, just for my understanding, particular to the 21, are those are just based on estimates, right now?
Correct. Yeah. And as we get closer, we fine tune. But what we do try and do is we try and make sure that we're not going to have to increase that number. Okay. Last year being the exception, we did have to increase last year, which is the first time, in my tenure here, we've done that. So yeah, these are just budgeted numbers. And as we get closer, we'll fine tune those.
At what point did you go out and start getting quotes?
Really, once we get the go ahead from the board, we'll start the pricing at the end of November. That gives us ample time to get ahead of the curve. So we're not, we're getting out to contractors before they've already got a book of business planned. And that usually ends up with better pricing for us.
Okay, thanks. That was just for my own personal knowledge. Thanks, Eric.
Sure.
Thank you, Guillermo. Julie?
Nope, thanks.
Julie's good. Thank you very much. Ted?
Nothing, thanks.
And Jason?
I'm good. Thank you, Eric.
I am also good. Eric, thanks so much and appreciate that. Thank you, Dave.
Certainly.
Okay, our next item is the Hadley Library Media Center technology purchase, and it looks like Eric and Mike both will facilitate the report. Mike's stepping up to the mic.
Yeah, this is a recommendation that will expand the microphone solution here in the library, the LMC at Hadley. We currently only have one microphone for this space, and there have been multiple opportunities where we could have had additional mics for various meetings, PD sessions, and that sort of thing, as well as it will provide for a full set of microphones for board meetings like this. So 12 microphones is what we're recommending. It's a solution that will be configured to work with the existing AV equipment here in the library. They'll be wireless. They'll be very similar to the microphones you have right now. They're desktop microphones. The only real difference is they'll be wireless. And it'll give us some flexibility in the space as well if we want to move things around or do the board meeting slightly differently.
Okay,
Happy to take any questions.
great. Thank you, Mike. Let me start. Guillermo, any question for Mike?
No, thank you, Mike.
Thank you very much. Julie, any questions for Mike?
No, thanks, Mike.
And Ted, any questions for Mike?
Not to get too nitpicky, but I'm wondering about any handheld mics as well. Anybody who might be wanting to do a presentation or something.
Well, and we still have the one handheld
Okay.
that we currently have with the system, so
All right.
we will retain that.
Okay, so that's compatible with what
Yes.
you're proposing. Okay.
Thank you. Thank you, Ted. Jess?
I had a few questions that were answered already, and essentially, it sounds like you can use the microphones that you'll get for the LMC with the system in the auditorium as well.
Well, we'd have to have those integrated in with the system in the auditorium.
Okay.
Because that has its own rack system with microphones already embedded. So it could be done. But we'd have to plan for that, and we'd have to have that configured with that system.
Okay, so that'd be an additional cost to do
Correct.
that. Yeah, because my understanding is you can have 6 wireless mics at a time right now with the current system in the
Right.
auditorium versus the 12 in the LMC. And I know they're always wanting more mics for the
Correct.
performances. And yes, okay, that covers that. I wasn't quite sure I understood the response.
Okay,
So thank you.
Thank you, Jess. Jason?
I'm good, thank you, Mike.
Mike, I am also good. This is a positive step to see the district bringing this forward to address the
Sure.
sound and bring it up to date. So thank you.
All right. Thank you.
Okay, and the third, feel like we've had a lot to say about saliva-based testing, but we do have a report and there are some options here. So the third topic is our saliva-based COVID testing options. Melissa, will you
Sure.
facilitate this, please?
I'm going to reference the table that was in, that's in the report. So as of today, we've done a look at Saliva Direct and what the Yale test protocol can offer to us. That would be the option investigated through DuPage Medical Group that Dr. Phillip came and talked to us about. Just do a quick review of the pros and cons, but pro is that Saliva Direct is a PCR, so it's considered the gold standard in testing. It does not require confirmation test after a positive result. Obviously, as they've discussed multiple times, there's a higher level of accuracy. Results are provided within 24 hours, and it does not require a medical professional to administer. One of the cons, just out of the 3 options that we're going to discuss, is that it is a little bit more costly. We are, after speaking with the DuPage Medical Group, they are not looking to make a profit off of testing. As a matter of fact, quite the opposite. But this will cover what it costs for them to scale up their lab. They had said that they believe if they took on a district our size, that they would be running their lab machinery basically 24/7. And this does require the availability of specialized equipment and supplies, which is one of the things that they will stay in touch with us from DuPage Medical when they have a better idea of where they stand with hiring their additional lab techs and when they can get an ample supply of some of the pipettes, I believe was what he mentioned. They're having trouble getting ample supply, which would be needed for those tests. So we would not be in a position through DuPage Medical Group to start anything in the very near future if that was the option that the board wanted to consider. U of I, the Shield test, again, it's a PCR test, same pros as Saliva Direct, slightly less costly than Saliva Direct, but more costly than the third option that we're going to discuss. One of the cons or concerns with the Shield program is at the current time, as we talked about last time, they were unable to contract directly with school districts. We've been told that that has been relaxed, but in terms of a timeline for when these agreements and contracts could be executed, we don't have a timeline. So there would be an undetermined delay before we would be able to begin any testing program with Shield, Illinois. The third option that we've been looking into is safeguard screening, and it is what was referred to tonight as RT LAMP. It's a less expensive option, about $11 per test. Results are provided within 24 hours, and it does not, as you heard, require a medical professional to administer. They are slightly less accurate. They are not FDA approved. There is some increased potential for false positives and false negatives, and they do require a follow-up diagnostic test to confirm a positive case. But as was talked about by Dr. Wiley, is that they are a less expensive option, which makes this more accessible to districts and perhaps more realistic from a financial standpoint. So again, that accessibility and sustainability, where you might give up some of the accuracy in testing, it is a model that is more accessible to and more sustainable for a school district. We heard both Cheney and Dr. Wiley say that frequency is really important. So what the LAMP testing would afford is that ability to sustain this longer and perhaps do it more frequently. I timed out here for a minute. So those are really the three options available to the board to consider. And, we will be further investigating the LAMP testing protocol and what's involved in all of that. But that's pretty much where we're at, is that we know that there are two options that are considered a gold standard. They are more expensive. Unfortunately, neither place, whether it's DuPage Medical or Shield, Illinois, are quickly able to initiate a testing program with us and get that up and running. One of the benefits, if we want to further consider and investigate LAMP through safeguard screening, is that they would have the capacity to partner with us in the near future. And again, they are a far less expensive option. So I'm gonna, ask Bob to go around the group and try to get a sense of, does anyone want to dig further into Saliva Direct, Shield, Illinois, or have any thoughts about bringing back additional information regarding safeguard screening and see if that might be something that could meet our needs in a more timely manner, knowing that we would always have the opportunity, well, not always, but that we would have an opportunity to reach back out to Saliva Direct or Shield, Illinois, if their situation changes and they can pick us up in a more timely way.
Okay. And actually, what I'd like to do is ask the board, particularly around the safeguard screening, the third option that Melissa talked about. We've heard a lot from the Saliva Direct folks, and they've described a testing regimen and a process that's going to closely mirror what Illinois Shield would also be talking to us about if they were here. There is a price differential based on capitalizing labs and buying equipment with DuPage and Saliva Direct that does not come into play with Shield, Illinois, which is why the pricing difference occurs. What we haven't done is had a conversation with anybody from safeguard screening. We did provide you with information in the packet Earlier today, I had a conversation with Dr. Ed Campbell, who is a professor at the Loyola Medical College. And he is working with LaGrange 102. And they've been doing the safeguard screening. They've been doing it for about 10 weeks. And you can go to their website and they've got a COVID dashboard. They've done 10,000 plus tests. So they're doing that RT LAM, which they acknowledge a little less accurate, but has proven to be a really good option, as Dr. Wiley and Cheney Kalinich mentioned. So I got some preliminary information from him, but most importantly, I asked him, would he be available to come to a board meeting and answer our questions, talk about what they're doing at LaGrange, what they're apparently going to start doing at New Trier, and what looks like it's going to be done in other places. One of the great advantages beyond the price is that they can scale up much sooner, and they can give us a date, which would probably be some point in November where they could begin to do this. And we wouldn't be locked into anything that would keep us from transitioning to either Shield or Yale DuPage. So I ran some dates by them, and what I'd like to know, and the board is certainly free to ask any additional questions or comment about some of the other options, but would the board consent to a special meeting on Monday, so the following Monday at 4 o'clock? Dr. Campbell would be available, and I think the board would need to hear from him so that we would have enough time to have something formally in front of us so that we could perhaps adopt the testing protocol and get to it some point in November. But it would require a special meeting with Dr. Campbell. He is available.
When did you say?
Monday at 4.
And can we be remote for that?
Well, certainly he can. I mean, can we? Well, I think we can only be if you meet the exemption. So you would have to qualify to be meeting remotely. We would still have to have a quorum physically here to do it. So
Is childcare still a valid reason?
I think if childcare is related and connected to
COVID.
the lack of childcare because of COVID,
Yeah.
I think we can certainly consult Todd, our attorney, but I think so, yes, Jess.
Yeah.
Yeah?
Is that the 31st?
No,
No,
Monday
that's
is the
Second.
second.
Oh, so 2 weeks from now?
No, it's only one
Coming
Monday from now,
November
Julie.
2nd.
I'm on the wrong month.
You are in the wrong
Never
month.
mind. I'm like,
Yeah.
that's Halloween. That sounds like a bad time. Okay, got it. November 2nd. My apologies.
So it would be on Monday. Ted, could you?
Yeah, I can
Yeah,
make that.
Jason?
I can make it work.
Yeah. Guillermo, could you make that?
Yes. Yeah.
Okay. All right, so we'll set that up. And I don't mean to preclude any further conversation on this.
Before, say we're going to set that up, what's needed present for a quorum to see if we'll have a quorum to set up a.
We will have a quorum if everybody,
Well, Jess and Julie, so they may have of a childcare issues.
Well,
I just
don't
want to
know.
make sure we can.
well, that's a good question. So 1, 2, I don't think we would, I don't know that
I'm
we
not putting
would.
you in
My
a quarter,
husband,
I'm
so
just
I don't
saying.
know.
I think we need 4 here physically present in order to hold the meeting and allow others not to do
I'm
this
putting
this
something
remotely.
on my foot.
So we would need a 4th.
Julie,
I can probably.
So let's
figure.
see if we can pull that off. We'll plan for that, and hopefully we can make that happen. Okay? Yes?
Okay.
Okay, good. All right, so let me open. Any questions, comments, reflections on what you heard from Dr. Wiley and Cheney?
honestly, it doesn't matter at this point if we don't know that they can really do any testing or screening for the district. I mean, it'd be great to have a discussion, but until we know that they're, that DMGs has the capacity to serve us, we really don't have an Illinois Shield option because we don't know what they could serve us.
Right.
We don't have a DMG/Yale Saliva Direct option because they don't know when they can start serving us. And the only potential option that we have right now that may be on the table would be this RT LAM testing.
Yes.
Okay.
And both DuPage Medical, Yale, and Illinois Shield are projecting and hopeful about getting a green light in December, being able to go in December. The University of Illinois has one additional hurdle, and that is that through the governor's office and IDPH, there will be certain districts that will be part of pilot programs. So it's not even clear that we necessarily would be able to just step forward and do the contracting with Shield. We would have to put ourselves out there as a pilot school, and which I think we would do if the board felt strongly enough about it. But so Jason, yes, your point is correct. I think in the short term, close to when we open up schools, safeguard screening, timing wise, is an option. So that, which is why I want you to have a chance to dig in. Any other thoughts on this topic? Yeah, Jess?
Yeah, I mean, with the rate of community spread where it is, I think it makes it all the more important for us to do screening. And I think the consensus was something is better than nothing.
Yes, ma'am.
And, I know all the data that we have available to us, and I think in one of the articles I've read, there's like 8 different data sources that people are using to say that the transmission in schools is really quite low relative to other transmission. But there's also consensus that that's weak data because we don't have the surveillance testing in place in mass in a lot of places. And so it's not giving us, it's missing cases.
Yep.
My level of discomfort with the community spread of red is through the roof. So I understand that I have that bias, but I think as we are looking to bring an age group that's 10 and above back into our schools November 4th, while presumably we will still be in red, hopefully on the way down, but very well could be still snowballing up, makes me incredibly uncomfortable. And I don't know that I feel good even with the test, to be perfectly honest, but that's, again, back to better than nothing. And I definitely think we should be very cognizant of what we're doing on the 4th.
I agree with you wholeheartedly.
I'd like to assure you, we are very cognizant of that. Hours and hours a day, cognizant of that. But would I feel better if we had a plan for testing? Absolutely.
I mean, I would feel better if we weren't admitting students until we have that testing in place. That's where I stand on it. Not K2, where we're at, I think the data is even more clear for those ages, but I think we're in that really, really gray zone when we get 4th grade and above.
To that point, Jess, and I wanted to be conservative and not overpromise, but Dr. Campbell felt that if certain things fell into place, and a lot of it is just being able to get the supplies, because the demand is now going through the roof, that schools are going to start doing testing. And like a lot of schools, they're not necessarily able to align the tests. Ideally, a week before you would start. But he did say if things fell into place, that testing could conceivably happen that second week in November. So we would be open for a few days and then the testing could start. And it could perhaps start over the weekend. Now again, he didn't want to overpromise, but because equipment has to come into place, so, which is why he suggested 3rd. That may only go some ways to easing your concern, and rightly so, but perhaps that timetable will be operable. Okay, yeah, thanks.
Wouldn't that mean that at our special meeting, we would have an action item?
If we
Well-
were to start that second week, it would have to.
Right?
Or we would need to have another special meeting. I guess it would depend on how comfortable the board was with the extensiveness. I think Dr. Campbell's going to have a lot to share with you. And I think he can put a full proposal together. And I will also say, they have a contract with New Trier. And our council is also council at New Trier, and that contract is available and it can be cloned. In other words, I'm sure our council would need to go through it, and we need to work out just how much testing we were going to do. There would be some differences, I'm sure.
You
But
say the terms have been agreed to. that the
yeah,
council is
yeah,
comfortable with.
yeah. So I think that could happen pretty quickly. So it's certainly possible that at that special meeting, we could have it as a discussion and as an action item. If the board is comfortable with that. I certainly see the value in having this done sooner, but if the board wanted a second meeting after hearing from Dr. Campbell, we would
In all
look
honesty, I don't
at the
know
calendar.
if, it'd be great to say, yeah, we could make a decision as to action on Monday. But it's difficult without any real information on it. Well, granted, we did get some information in the packet. To say, yeah, we'd be ready to go on Monday as opposed to what it said back, digest the
So-
information.
So I'm looking at Nancy. So Nancy, we would hold a special meeting on Monday, and then our board meeting would be November the 9th.
I
So,
mean, it's 48 hours. You could say you'd come back on Wednesday if people were available to. You could have it on the agenda for an action item.
no, you need 40, you're shaking, you need 48 hours.
Right, it's 48 hours, Wednesday. Right, I mean, my point is that we put it on for an action item. And then we could just test the waters to see where people are. We
Ready?
could make a decision,
No.
table the action. No, I know what you're saying, but I'm just saying without an action item on the agenda, you can't take action.
Correct.
If you have it on the agenda, you have the option of tabling it to come back and it's for a second meeting.
That's true. It does give us the flexibility. The question is, would we be able to put a special meeting in terms of what everybody has
Right.
going?
We could, I guess, something to consider is if this is the only item on for the special meeting, I would suggest that you take ample time to talk and ask questions and discuss. I'm not sure what new information you'd have in 48 hours, that
True.
you wouldn't have after devoting however much time is needed at a special meeting. I'm not sure there'd be any new information to bring to the table within those 48 hours. So that's just something.
Is,
It's correct.
I mean, I know we all were phone.
Okay.
Like if you were looking for something, it might be.
Well, Well, I want to just see, Guillermo, where are you?
he's on Zoom.
I want to make sure, so obviously you're listening intently to what we're talking about here. There does seem to be an argument for having it listed as an action item. It could always be tabled if we felt like we needed more time. Later in the week, we would put on another special meeting if we did. Are you comfortable with that?
I'm very comfortable with that. I'm actually like in the same boat with Jess because of our biased situation. And I mean, it just scares the heck out of me that our middle schools are going back to school in a few days. And any testing is better than not testing. And if we can get our answers on Monday and make a decision and have a quick turnaround, I'm on board with that.
Okay, thank you. Ted, how about yourself?
Yeah, I'm fine with that.
Yeah, Julie?
Yeah, can I make a comment?
Oh, please, yeah.
I think this is a really valid thing to look into because in one of those documents, one of these mini documents in the testing section, right? There was a table somewhere that sort of said the United States, people in the US think that the sensitivity is the most important thing over cost and speed, right? But what the data tells us is that the sensitivity is actually the last thing you need to worry about. The cost and speed are definitely more important, right, than the sensitivity of the test. And so even if this isn't particularly sensitive, they also have not had any false positives as of October 19th.
Mm-hmm.
And it does require a follow-up diagnostic test. But I have a friend in the LaGrange district, so can I make one comment?
Please.
I asked her some questions, and I know it's not appropriate to bring up my phone, and I didn't take notes, so it's going to be off the top of my head because it's all on text messages. So they do this, I think she said twice a week, and they send the tubes home with the kids, and the kids spit in them and bring them back the next day.
Mm-hmm.
So if there's a suspected, what'd you call it, like a probable positive, because it's not diagnostic, so it's not, you can't be told you have COVID. You probably do. You should go get tested.
Right.
Right. They pull the kid and they get a diagnostic test, I think, in the nurse's office. I think. They go to is that not right? I thought that's what she told me, but her kid hasn't been involved.
Okay.
But
Wow.
yeah. So anyway, that's what she told me. Whether or not
Okay.
that's true, but
You can do a diagnostic.
or that's at least what she understood.
Okay.
What, Dr. Kay?
I don't think you can do a
Like through this organization, it's not
Unless
like
they
part of
were,
their
unless
follow-up
they were
pilot
on
program?
site.
yeah, you'd have to have medical staff on site
Yeah.
to be able to do the diagnostic test there. And then it would still have to go somewhere in
Well, right, they
order
couldn't get the
to run.
results, but I was thinking the kid would like submit, spit in a thing to send away or whatever. I don't know. Anyway, it seemed like a pretty slick deal, and she
Yeah.
said there's only been a few probable positives.
Yep.
So that was really good, but I think the, frequent testing, and even if it's not perfectly,
Mhm.
accurate, that's, like everyone has said, it's better than nothing, and it's certainly,
Yeah. And by the
certainly
way,
helps, especially with as Jess alluded to, the immense community spread we have in this area right now.
and the increased frequency, by the way, captures and picks up some of
Right,
that
and there are
accuracy.
charts in these mini documents that show
Ample
the,
charts.
show the R0 factor or R naught,
The R
whatever they
naught.
call it.
Right.
Um,
Okay.
Yeah.
Okay, good. And Jason? Well, actually, it was your idea to have it as an action item where we could.
Yeah.
do- Okay.
Yeah, I'm typically in favor of a two-step process, but I do feel like that's actually our third meeting on this topic.
Yes, that's
Uh,
correct.
So I feel like we're covered
have.
in that sense, and we've been talking about costs all along the way.
We have.
So it's certainly something people can extrapolate. I forget, it's great that they haven't had any false positives. Do they have a way of uncovering false negatives in the sense that they would have a child test for COVID outside of this protocol that wasn't captured by the screening?
We can ask Dr. Campbell that specifically, but on the website, and obviously, Ms. Hill, you were looking at it, or you knew that data, they recorded, and this was district-wide, 6 positive cases. So they don't seem to be having a problem with false negatives. There hasn't been a spread, and there's been the 6 cases that they were able to easily contact trace. But we can ask specifically about that. Yeah.
I know that area is not that far away from where we are. Is their community spread significantly different than ours?
It's Cook County. So
Right,
thought
I
he
know,
said-
but
I thought he said that it was also insubstantial now.
is it pretty similar?
Yeah, I think that's what he said.
possibly higher. Well, Cook County is
Yeah.
higher than us, but we'd have to look
Yeah,
up
but it's like just
LaGrange.
barely.
Katie,
It
you
is
don't
on
have
the
it
other
at
side
your
of the line.
fingertips.
Yeah, we'd have
Come
to
on,
look
Katie.
up, we'd have to look it up by zip
Let's
code.
get on their
Yeah.
zip code.
Yeah, I should probably have it before the meeting's over.
She probably knows in her head.
Okay,
Got the tabulations.
I understand. Okay, well, we've got a way forward then. The fourth and final item is the Illinois Association of School Board Resolution recommendations that Ms. Hill has gone through a lot of time and work, and you've made recommendations to us. So do you want to
I did.
invite the board to
Sure.
comment?
So the thing that I can remember to tell you in the board reports is that we have the support of the League of Women Voters on our resolution. So they sent out an email to all of their members to say, please call and email and show up at your school districts to support this resolution. So that was super exciting that a statewide organization is backing us on this. I'm going to do like lightning speed through each one.
I think that would be a good
Does
idea.
that work?
That would
And
work.
I can talk fast, so ready? So number 1 didn't appeal. They were not recommended and they didn't appeal, so it will not get a vote. Number 2 is us. Number 3, so you've heard enough, right? So I'm going to recommend that we adopt number 2. That's going to surprise you. Number 3 is talking about the school report card. Essentially, that's like a logistics problem. The date they want it submitted can't be done because they don't
Right.
have the information. So that, like, it just kind of can't happen, at least for now. Number 4 has been a topic of much debate, I think. But as I was filling the ends of this thing out, it suddenly occurred to me, I have like these experts at my fingertips. Why don't I just send these experts an email? And so Dr. Kay and Dr. McCluskey responded supporting this. It will give teachers more tools to help children help children learn how to read, which was sort of my initial thought. But I know there are lots of thoughts
Can
about
I
it.
ask a question about that one? If you don't mind me just interrupting.
Yeah.
How is this a teacher education program and a university issue and not a teacher licensure issue? Teacher licensing issue.
Well, I think the point is that if you get a license, you should have had this instruction.
I understand, but I mean, the ISB is separate from universities, and so university has set up their curriculum to get a teaching degree in X, however they want. If it doesn't meet the licensing requirements, that's on the university. That's what I don't understand what the ISBA's position.
Say it again.
I'm just reading the ISB position. Historically, ISB has not taken position on teacher education programs at universities. And I don't understand how a licensing requirement has anything to do with university education programs.
Because you're going to get a license through
It's
after
indirect.
attending a university.
No, it's indirect. I mean, if your university doesn't give you the classes that you need to get your licensing, you might not want to go to that university to get that degree. But
Right, but
it's
they're saying this is something that should be required to get the license.
right, but and then universities could adapt if they wanted to. That's what I don't understand how it's not really affecting an education program, but it's only indirectly. That's what I.
Well, I mean, they amended it. So you have to look at the amended one. It doesn't mention the licensure at all. So the amended is at the very end of number 4. So what we would be approving or disproving is the statement as amended. And it's just the one little paragraph before number 5. And it's more about supporting initiatives and teacher preparation programming that prepare teachers to be trained in scientifically proven methods of reading instruction that promote student literacy. So they took off the licensure piece, and it's really more about advocacy of training programs.
Right.
Yes. So they took it away from the licensure aspect because the requirement was too restrictive because of the teacher shortage.
Right. They want teachers to be better trained for this particular skill, and D41's cabinet agrees that that would be a really.
And there's also a chicken and the egg here, like if it's required for licensure, but there isn't a single program that has that as part of their
Well,
requirement.
the universities will be like, oh.
Yeah,
adapt.
right.
They'd adapt.
I mean,
that's
there's a
not hard
gap.
to do.
Yeah.
Yeah. And some of them already are. I mean,
Mhm.
I took a class on this, that was a while ago, but
So Julie, you were recommending that we adopt, particularly with
yes,
amendment that just explained.
yes.
Okay.
And with the support from the D41 cabinet.
Well, and I think having a resolution on record that's advocating for a teacher preparation topic is actually a really good thing to have, because I can see us down the line wanting to add one for equity measures
Yeah.
so that our teachers are coming to us prepared with cultural competence.
Yeah.
Okay. Well, actually, a good amendment by the committee, or the committee approving the district that submitted the resolution amendment.
I know you went through the other ones quickly. For number 3, where the dates and the scope are not appropriate for the testing, getting the state testing results back.
Yeah.
I mean, the sentiment is actually quite good. There's so much
Yeah.
frustration with it.
Right.
And
'cause
so
it
it's just
comes
a
like
matter
November
of
or something.
changing the dates.
They don't get, I can't remember all of the information that goes in the report card, right? But some of it doesn't school districts don't have that information in the time that this amendment or that this resolution is asking for.
Yeah.
it.
So I get the,
So like November is really late, but like June 1st is not doable.
right,
So
yeah.
there's gotta be,
So
some
I'm
happy
just,
medium somewhere.
I'm wondering if we want to put that on our back burner if this school district doesn't revise it for next year, that we do a little bit of research
I
about
see.
what timeframes would be practical and just amend the dates and the scope.
Yeah.
Because I
seems
think
like
it's a good one.
intention. Yeah, it's a good intention. It's just like logistically, I'm with you.
it probably just needs a few more conversations on the front end before writing it. I don't know with who, but
Some more information.
I bet
right?
Melissa can point us in the right direction.
But Melissa knows it. She's like, nope, that's the problem there.
School report card.
Yeah.
Yeah.
Okay.
Yeah, I was like, just make it concise. So I'm just like trying to do that. But please jump in. Please jump in. The teacher shortage, number 5. They're very simply, I think, trying to make it easier to be a teacher and to get a teaching job.
Mhm.
And I think the state of Illinois has actually done this already on a couple of things over the last decade, probably. Teacher shortages are widespread. There is ample research into why there are teacher shortages. And I think making it easier doesn't help the problem. It just gets you less qualified applicants. And if we want to fix the teacher shortage, we need to follow the data on why there is a teacher shortage. That was sort of my stand on it.
Well, and I didn't quite understand what new ask was in this one, because it seemed like in the, unless I was reading it wrong, that in the committee's response to it, they were saying that these things could already be filled under existing
Right.
things. So I don't know why we would add it. So I'm just kind of in favor of not adopting it because it doesn't seem like a new thing, addressing the new need, unless I'm missing it. But I like what you're saying about how we should be addressing the root cause, and I'm
Right.
wondering, and I can guess as to what the research says about what those are.
I mean, there's the sentences that articles skip over when they want to pontificate about a teacher shortage. Like, it's the first paragraph that they just skip over and keep going.
Yeah.
That's it right there.
So maybe I mean, you can put it on your list for next year to create a resolution
Your list is growing.
at the core.
I know. Well, I'm not sure I'm going to be on this next year. I don't know whose job this will be.
No, I think you're doing great.
Okay.
Okay. And also D200, which is our Wheaton neighbor, spoke on this during the Zoom call. And they were also concerned about downgrading educators and education. And they had a discussion about how there's a difference between an educator and a presenter. And you don't just want a presenter, you need someone who knows how to teach. And they were concerned about devaluing that. So I thought that I wrote that down. I thought that was insightful and I agreed with them. So confirmation bias. E-learning on election day. I think that sounds like an interesting idea, but to my understanding, election day 2020 was dedicated as a state holiday, with my understanding, and I didn't go find this in writing, but was to make it easier for people to vote, was to give people better access to voting. Is that?
Well, it's a school holiday, including school offices. And I believe it was because if we're being used as polling places, we're
Right.
keeping kids and staff out of the building when people are using it for voting purposes.
But it's not just for schools. Like it was like a statewide thing, wasn't it? Or it's not, it hasn't happened yet? I don't think it's just like a school thing, is it?
I believe, well, it's not the same as, I'm not sure who else has off, but I know it's a school holiday.
Yeah.
So.
And I guess the idea is that just because you can't be in the buildings doesn't mean you couldn't teach them if you were able to. It just gives an option to do e-learning on that day, even though it's a holiday, right? Or if now, because it's a holiday, the point is moot and you wouldn't. That's kind of a question.
That was sort of my thought, but I'm open to persuasion.
Melissa, on a school
People have
holiday,
strong
can you
views.
still teach?
We are not planning on it. We've already factored that into our year. So any change would have to go back to a
You'd have-
calendar.
Well, this would be for
Right, but
future years
theoretically in the
anyway.
next,
I've been told that this is the only year that they're going to treat this as a school holiday.
If I can address it, it's pursuant to the Illinois code, it's election day, it's a state holiday. Now, it's notwithstanding any other provision of state law to the contrary. November 3rd, 2020 shall be a state holiday known as 2020 General Election Day and shall be observed throughout the state.
yeah, that's what I thought.
Yeah.
So
not
it would apply
beyond.
to state
I've heard
agencies.
that beyond.
So not next year potentially.
But that's
Correct.
weird that it's not like down the road. It's just.
No, it's probably to address this year's issues.
COVID.
a COVID issue. So you can have a public buildings, state public buildings opened up for polling places, and not have to worry about having children or staff in the buildings.
But I mean,
at
I
the
don't
time.
think that I taught in a school that was a polling place and that was creepy. Like,
Listen, it's
I
not
don't
creepy.
think it's a good I don't think it's a good idea in general to have a bunch of like
And that's a conversation for a
townies
different
walking
day.
through, right? Like a bunch of random people walking through when like there's so much, and not to say like people are bad, but like there's so much concern about school security, and to just like open it up wide open on like a random day and have all these people in hallways and their gyms, and that puts the kids out of different rooms.
Yeah.
I mean, I don't even know if that happens in Glen Ellyn, but it did when I taught in Chicago.
When I
So
thought-
it
when I
just
was a
doesn't
kid.
seem like a good idea anyway.
I would say as far as the resolution goes, there's no harm in it. It just gives more options to districts. So
So to be
I
clear,
would support it like the committee recommends.
so the committee
What do you guys think?
is recommending to support it, to provide that option for e-learning. And Julie, if I understand, your recommendation is the state created this as a holiday because it wanted to optimize during COVID the opportunity for people to not have to.
That was my understanding,
Yeah,
but
and
if
I'm
I'm wrong, tell me I'm wrong.
No, I think that's correct.
Well, I don't know how you could get around having it
And I think you're right.
e-learning when it's a state holiday.
I don't know how you would either. I don't know either. So, all right, so so I would be supportive of Julie's recommendation, but we may be we may not be, we may have to go through and vote on each of these individually before we
That's okay.
direct
Yeah.
Julie, which is okay.
I don't feel that strongly about it.
Okay.
I'm open to discussion. This was just like my understanding was this, but if you know more. and
Well,
June,
this
like-
this resolution would not impact this school year, so we can't be talking about this school
Well,
year.
and that's why it's kind of
We have to
silly
be
on both
talking
ends.
about school years beyond,
And
Right.
it's-
and
doesn't
it
address
wouldn't
school
be a
years beyond.
state holiday.
It doesn't go beyond.
And so the creepy people would be in your school
Sorry. Those are
because it wouldn't be closed unless they made this a school holiday again. And so that would give schools the option of being remote.
Mhm.
maybe we need a
in that
resolution
situation.
says don't use schools as polling places.
Well, that's another different.
Maybe
That horse is out the door.
Maybe that should be another.
Yeah, I
What?
think it's too.
That
That's
that
another
horse is out the
conversation.
door, or out the barn door. All right, let's,
Yeah, the act says it's for 2020.
Yeah,
Yeah.
yeah, that's what.
yeah.
But this resolution
10 ILCS
isn't gonna be
5/QB
effective
dash
until-
10.
So would we expect that this would happen again?
It would have to be they'd have to amend the code.
What will happen again is that your school will be a polling place
Right.
That's
and it won't
likely.
be a school holiday.
I'm wondering if the school holiday would be expected to be repeated, not the polling place.
Well,
It's not anticipated to be, is what.
Oh, really? This is just COVID related?
that's, I
You
think, the
think?
anticipation.
Okay.
So your do not
and-
adopt is consistent with the resolutions committee's recommendation. Do not adopt.
Except this
It's-
piece of
It
paper
says
says,
do adopt,
this piece of paper says do adopt.
yeah.
Did I get it wrong?
Oh, you did, Julie. I'm sorry. I looked
got
at
it
your
wrong in
notes.
the
Oh,
thing?
that's okay.
I'm
I was
sorry.
looking at your notes. I turned my head to look at your notes. Okay, so the resolution committee is to adopt, and
I'm sorry.
that's
My
okay.
bad. I did put it wrong in there though.
And
I'll
your
fix that.
recommendation would be do not adopt. Just to be clear, okay. And then we have what turns out to be one more resolution because of number 8 was merged, but go ahead, Julie, I think we got one more. The local control pandemic resolution.
Oh, okay.
Yeah,
I didn't feel settled about 6. Are we
well,
settled?
if there's more
Are we
that you have to
settled
say,
about 6?
no, if there's more that you wanted to bring up, well, we
No, I don't know. Do you guys, I don't know.
I think it's so
I'm
nice.
due adopt.
You're due adopt?
I'm due.
Okay. I don't know. What to say.
I don't think it matters in the least.
What
Because
I'm
what are
gonna-
you going to vote on these things?
November
November what?
14th.
and we're
Okay,
not,
then this is just poor planning because that's going to be all said and done and it's going to be irrelevant.
But it's
Right.
not for this year.
But
It's
it's
for
not
future
this-
years
it would
when
be
it's not
in
a holiday.
future year, 2022 or 24, or name your even years, right? To have e-learning. So I guess if you
No,
think of it that way,
sounds
Josh, I
like
get
a
I
mental
get what you're
exercise.
saying.
we will have an opportunity, just to remind people, we will have, we're not actually taking action on it tonight.
No.
Oh, we're
So,
not.
no. We will have an opportunity before the delegates meeting We are going to have an opportunity to do that. We can have,
I thought we were voting on it tonight.
we are not.
Oh.
It's not listed as an action item, and we have
You're
the
right.
first meeting in November.
Okay.
So you will have opportunity to sort of think this through, and you can take in everything the board members have said about each of these resolutions. But we'll have to take action that night.
Okay.
Yeah, okay? Well, you're good. That's okay. It's a discussion. You
Okay.
actually-
Number 7, local control of the pandemic. This is what we're already doing. But I also think school boards shouldn't be in charge of making these decisions. This needs to be a public health decision. And to be like really nitpicky, they talk about encouraging members of the GA and whatever in state and federal courts. Like, I take issue with trying to lobby courts about things. So I guess I just don't like school. When you get to like local control with IASB, I feel like that means school boards, and each district would make their own decision. And I'm not sure, that we would all consider ourselves experts on how to handle a pandemic. And I imagine that most other boards are similar to us, right? So I don't feel comfortable being the ones to make those decisions. I want that to be above me with people who know more and are smarter about those things. And I don't think we need to be lobbying courts. I think that's crazy. And 8 was similar, perhaps better, and that it was more specific, but it was the same idea. And so the committee said, never mind 8, 7's the same, we'll go with 7. I don't know how you guys feel about the local control for a pandemic response. I mean, to me, when you look at countries around the world versus the US, and you see the ones that have had strong national responses, and then you see our local control response, there's definitely a difference. So I'm not sure I agree with local control on that particular issue.
Okay. Any reactions, reflections on this one or any of the others?
Well, I do agree with Julie. It's a little strange that they talk about Illinois General Assembly, U.S. Congress, state and federal courts when we're talking about a health issue. That
Yeah.
really should be Department of Health making those decisions, and how this current situation has been shaking out. There are local decisions being made. Right? This seems to me like this was probably in reaction to what happened in the spring when
Oh, definitely.
when the
So it's
governor said, okay, we got to close all the schools.
Oh, I see.
Right.
The
Yeah.
closing, I see. No, you may be right.
Yeah, I think one of them had that in the copy,
Oh, is that right?
in the text, I think. Because
Okay.
that was,
Great. Okay.
and then the existing position statements are just about charter schools and wanting the local funding, public schools to have some say and some oversight.
Yes.
So I think in the past, we've all agreed without conversation about those. So unless you want more conversation about charter schools, I thought those were pretty well decided.
Yeah, I'm good.
Okay. No, I think we're good.
Just a couple of comments. I think it's worth noting that there's belief statements, and do you get to vote on those as well?
Yes.
Okay. And so this year, one that's being proposed is one based on equity and our commitment to that. And I wondered if, for future years, our board might consider additions of belief statements surrounding mental health, potentially around climate change, and what we believe is the role of schools and school boards in that. And those things. And then, and if anybody wants to talk to me about that, I'd be up for a conversation. And then, as we continue to work on this idea of equity and social justice as a community, and that's going to be going on here in our district and throughout our village, we might want to look at some opportunities for resolutions for next year with that kind of lens. So some things that just come to mind initially are the pre-service teacher training for cultural competence. You know, that's something that districts will be investing in the years to come, and it's an ongoing process, but certainly if that were folded into our pre-service teacher training, maybe it is, I don't know.
I can tell you, I was on a call for the EC back to school, and unbeknownst to me, I was the only white English person on the call, and it was a Zoom room full of Burmese-speaking people with a Burmese translator, and just reaching out to that cohort of the population of the EC program and making sure that there was a full understanding of the return to school protocols, what was needed, what questions were had, and that with an interpreter there who was lovely. And so I know that those steps are being made in the districts to certain pockets as necessary, and especially when there's a need for those subgroups.
In our district, yeah.
Mhm.
Yeah. But I mean, I think advocating for it at
Oh, no, that's
the
not about, I'm just saying
level,
what we're doing.
ways to get to the root of the problem of our teacher shortage and attracting, in particular, people of color into teaching as a first or second career choice. Hiring practices focused on representation and equitable funding at a federal level, whereas I think there's funding is talked about, but it's not from an equity perspective that I could tease out of it. So I thought that was interesting. Although it's starting to happen, right, with evidence-based funding. So just some food for thought for next year. Hopefully we remember it when it comes back.
I was actually,
I wrote some down, but feel free to submit them next year.
Okay.
when you were talking just, I actually went to the back of the booklet to look at what the current belief statements were, to see if any of the things you're suggesting.
Yeah, I looked at them.
Yeah, I'm sure you
I
did.
reviewed
So,
them.
yeah. Very good. Okay, well, we'll have this as an action item at the next meeting. And Julie, I want to thank you for taking all the time that you did and taking a
Yeah.
deep dive and trying to kind of get to the root argument and being part of a 2.5-hour Zoom call.
Oh, there's more.
Oh, yes, that's right. There's a second one. Well, that's an extensive effort, and it's what we expect from the board rep. And so thank you for doing this job so well. Okay, that ends our discussion items. We'll move on to our action items. The first is the consent agenda. Are there any items board members would like to be removed from the consent agenda to be considered separately? Hearing none, may I have a motion to approve the consent agenda, which includes employment recommendations, resignations and retirement on the personnel report?
Motion.
Second.
I'm not done.
Yes, you did.
Oh, sorry.
The school district payment order, but thank you, actually, really on top of things, of September 23rd to October 20th, the FOIA report, September 23rd to October 20th, the September 2020 financial reports, the October 13, 2020 open and closed session board meeting minutes as presented. Now go.
Motion.
Second.
Very good. Roll call.
Mrs. Hill,
Yes.
Mr. Guzman,
Yes.
Mrs. Buttimer,
Yes.
Mr. Estes,
Yes.
Mr. Lobach,
Yes.
Dr. Bruno.
Yes. And then we have a couple of superintendent recommendations. The first is to approve the additional crossing guards. I have a motion to authorize Assistant Superintendent of Finance, Facilities, and Operations, Eric DePorter, to pay up to the estimated amount of $31,012 for additional crossing guard services during the 2021 school year as presented.
Motion.
Thank you.
Second.
Any discussion? Very good. Mrs. Milk, roll call?
Mr. Lobach,
Yes.
Mrs. Hill,
Yes.
Mr. Estes,
Yes.
Mr. Guzman,
Yes.
Mrs. Buttimer,
I'll be voting no, just because I think it's rightly defined as a public safety issue. It should fall under the budget of the police department as it has.
Very
Dr.
good.
Bruno.
Yes. And the second item is to approve technology support and consultation. May I have a motion to authorize Assistant Superintendent Eric DePorter to enter into contract with Techno Consulting, Inc. for $2,000 per month through the end of the 2021 school year as presented.
Motion.
Second.
Any discussion? Roll call, please.
Mrs. Buttermer,
Yes.
Mr. Estes,
Yes.
Mrs. Hill,
Yes.
Mr. Lobach,
Yes.
Mr. Guzman,
Yes.
Dr. Bruno.
Yes. And then finally, to approve the fund transfer, may I have a motion to adopt the resolutions transferring funds from the Education Fund to the Operations and Maintenance Fund, and then from the Operation and Maintenance Fund to the Capital Projects Fund in the amount of $2,990,000 as presented.
Motion.
Second.
Very good. Any discussion? Roll call, Mrs. Smoke.
Mr. Lobach,
Yes.
Mr. Guzman,
Yes.
Mr. Estes,
Yes.
Mrs. Hill,
Yes.
Mrs. Buttermer,
Yes.
Dr. Bruno.
Yes. Are there any board governance, other learning together issues topic? Seems like a good chunk of our meetings have a lot to do with us learning together these days. And then we have upcoming meetings.
There's a new one on there.
What's that?
There's a new one on there.
Is anyone on there? What?
A new upcoming meeting. Remember the special meeting?
Oh, so we do have the special meeting that we will schedule. Thank you, Jason. For Monday, November the 2nd at 4 o'clock. And then we have the regular board workshop meeting, which is scheduled for November 9th at 7 PM. And then November 25th, we'll have, at 7 PM, we'll have our regular board meeting. Are there any items board members wish to suggest for a future meeting? Hearing none, the board does not have a need to adjourn to closed session, so may I have a motion to adjourn the October 26, 2020 regular meeting.
Motion.
Second.
Any discussion? All in favor, say aye.
Aye.
Aye. Thank you.